Um, Hi, good afternoon or good morning or good evening. I don't know where you are. Thank you for being here to listen to this journal club presentation. So I'm going to talk about this paper that was published last year, talking about the borderline proteinuria in healthy cats. Before I start a presentation. I'm just out of my own curiosity. If you want to poll, that'll be great. Or if you want to just unmute yourself to talk about it, or just type. I'm just curious, like, what would you do if it's a situation that you see a otherwise healthy cat with a UPC, for whatever reason you decided to do a UPCR is 0.3? What would you do in a situation like this? You can either scan a QR code to poll, or if you want to type, then someone say recheck in 1 month. Thank you for answering that. Okay, yeah, recheck in 1 month. Okay. So yeah, I think definitely it's no right or wrong answer, right? And then so upon recheck, the same cat still has the same UPC of 0.3. After say like a 1 month recheck, what would be your next step for this cat? Are you going to recheck still in a month or something else? If you pick other, would you mind share what's the other mean? You can type, or I think I can see things. Or consider SDS page. Okay. I think that's reasonable. Like I said, there's no right or wrong answer. I'm just curious of what people will do in a situation like this. Do a renal diet. Okay. Yeah. Okay. So I think there's definitely things that we can do, but I think at this point, we just don't have a consensus, like what's the next best strategy. So before I start talking about the paper, I just want to briefly review how kidney handle the proteins. I think you probably have seen this picture many times before. In healthy animals, there is at least 1 milligram per deciliter of the albumin in Bowman space. For the low molecular weight protein, they are freely filtered, but then they can be reabsorbed in the proximal tubule. Only a small portion of the albumin intermediate weight molecular weight protein will be filtered through, but they will also be reabsorbed by the proximal tubule, mostly at the S1, S2 segment. Some of them will be reabsorbed in the late S2 and S3 segments. As the glomerular disease getting worse and the permeability becoming higher, you will lose the restriction of passage to negatively charged protein like albumin, and a fraction of high molecular weight protein will also be filtered. And as the disease is getting worse and worse to the point that tubular transport mechanism is oversaturated, then that's when we see the proteinuria, high level proteinuria. So when we talk about proteinuria in people, based on my research and the KDIGO guideline, when they talk about proteinuria, they actually more so talking about albuminuria. They do urine albumin creatinine ratio is preferred over UPC because it's more sensitive, more specific, especially in early disease. It's considered as a gold standard. There are several studies out there. They see this UACR as a good predictor to assess the increased risk of heart attack and stroke in people, whether they have or without diabetes. And of course, we know that UACR, the albuminuria, also is an early detection of kidney disease, especially in diabetic nephropathy patients. based on the guideline, the annual check of those patients of the albuminuria is recommended for those patients. In some paper out there, like 2019 and 2020, they even mentioned that they prefer albuminuria, checking albuminuria as well, because they feel that increase in albuminuria can occur before a decline in estimated GFR. So the KDIGO guideline in 2024, they have this chart. They use both the GFR as well as the albuminuria categories to help the physician to assess whether this patient is a low or moderate or high risk of a CKD. And how they categorize albuminuria is like A1, A2, and A3, just like the light signal on the right side. A1 basically is a green light, meaning the albuminuria is less than, urine albumin creatinine ratio is less than 30 mg per gram. The yellow light meaning between 30 to 299 mg per gram, and the red light means above 300 mg per gram. Because I'm not familiar with this 30 mg per gram, what that actually means. But then later on, I realized if I just put the milligram and gram into the same unit, that just basically means 0.03 is the actual urine albumin creatinine ratio. So in human medicine, when the urine albumin creatinine ratio is above 0.3, they consider it as a high risk of patient having a kidney disease. So we know that proteinuria does not equal albuminuria, because proteinuria include albumin and non-albumin protein in the urine, even though albumin is the largest contributor. But recently, there are few studies out there in human medicine. They are trying to establish the relationship between albuminuria and proteinuria, because urinary albumin reagent, they could be quite expensive, and the resource may not be available in some area. So even in KDIGO guideline, they do recommend to use UPCR. The 500 mg per gram equals 0.5 as a surrogate to if a physician cannot check the UACR. This study is a meta-analysis study that was published in 2020. They want to know like how safe or is it okay for human people to use proteinuria, not to check albuminuria, just like what I mentioned earlier, because the price and resource. So this is a meta-analysis study. There are 12 research and 21 cohort studies with almost 1 million adult patients included in this study. What they found was at very low level, UPCR and UACR, they do not correlate well. As you can see in this graph, when the UACR is less than 30, it has a very variable numbers when you compare to UPCR. On the other hand, at a very high level, there's also a high inter-individual variability. So yes, it's true that they may not correlate that well in a very high or very, very low level, but this paper also mentioned like, however, at a very low or very high level, the treatments likely will be the same. You probably will treat the patient the same way. You may not necessarily changing how you treat the patient. So basically, they feel in this paper, just pick one test and be consistent. Luckily, we do not have this problem in veterinary medicine because we don't really measure UACR that frequently. UPCR so far is the gold standard. Albuminuria is more sensitive. There are two tests out there. One is semi-quantitative point of care ELISA test that was made by Zoetis. The other one is NTAC. You have to send out and they will actually give you a number. But as far as for urine albumin and creatinine ratio, it is not standardized. There's a paper they look into the reference interval in healthy dogs, but there is no reference intervals established in cats. This 2016 paper, they do try to correlate the UPCR and UACR. They found a strong correlation between UACR and UPCR. So at the end, this paper, the authors feel like there's no apparent benefit of doing UACR over UPCR. So we stick with UPCR for now. As far as for the proteinuria prognosis, we all know that proteinuria is a negative prognostic indicator in both dogs and cats. My intention is not to go into a huge review of proteinuria because Dr. Vaden and Dr. Chu, they did a wonderful lecture in core curriculum modules 2 and 3, and there are a lot of information there. So I will highly recommend you go back to review that. Iris staging of CKD. At this point, we will classify dogs if it's a protein UPCR between 0.2 to 0.5, it's borderline proteinuria. In cats, it's 0.2 to 0.4. Above 0.4 in cat, 0.5 in dogs is considered proteinuric. But how do we and when do we treat those patients? Based on the 2004 published in 2005 ACVNU consensus statement, in the non-azotemic dogs and cats and with UPC above 0.5, continuing monitoring is recommended. However, exact interval of recheck is not specified in that consensus. And the consensus also did not talk about what if they are non-azotemic, but with borderline proteinuria. So here comes this paper. They want to look into what's the clinical importance of borderline proteinuria in healthy cats. And they also want to see if there's any other risk factors for those cats to develop chronic kidney disease. Sorry. So the background is, like I mentioned, they want to look into what will the borderline proteinuria mean to those cats, especially in those non-azotemic cats. The rationale is if we can detect CKD early, can we potentially intervene earlier and improve outcomes? The primary aim of this study is to assess the clinical importance of UPC between 0.2 to 0.4 in non-azotemic healthy cats. The secondary aim is to identify any other risk factors for the development of kidney diseases in this population. So it is a prospective cohort single-centered study. They enrolled 201 healthy client-owned cats who were over 7 years old. But if they had any pre-existing condition or the blood work showed any of the pre-existing condition, they will be excluded. All of those cats will be re-examined every 6 months for 2 years. The primary outcomes are either develop a kidney disease like a CKD stage 2 or above, or persistent renal proteinuria. So how they include the cats or how they categorize the cat into true healthy cat or Iris stage 1 CKD cat is a little bit confusing. So I feel it's better if I kind of go over this part more in detail, because later on when we look at the result, it could be confusing when we look at them if we don't really know how they define Iris stage 1 CKD. So for those cats who had low USG, lower than 1035, they are not necessarily going to be stage 2 or stage 1, and they're going to look at the serum creatinine. And if it's less than 1.6 of the serum creatinine, and sDNA less than 18, they will be classified as stage 1 CKD. But also, if a cat has a high creatinine above 1.6, they are not necessarily be classified as IRIS stage 2. It could be normal, healthy, or IRIS stage 1. So how they classify it is, then if a cat has a serum creatinine over and above 1.6, they will look at the USG, make sure USG is over 1035 and UPC is less than 0.4. But then if the sDNA is above 14, this cat will be in IRIS stage 1 CKD. Then the statistically, I think they look pretty good to me. I'm not an expert, but I think they look good to me. If you find anything not kind of weird, please let me know. But I don't have any specific comments on this one. So for the result, they have 201 cats included in the study. 150 of them had UPC less than 0.2. 51 of them have UPC between 0.2 to 0.4, basically this borderline proteinuric cat. As far as for the age, sex, breed, weight, body condition, muscle condition, blood pressure, between the two groups, they are pretty compatible, as well as the creatinine sDMA. But when we actually look at the creatinine, if you look at the range of the creatinine of those cats, you will see like, oh my God, some cat has a creatinine of 2.1. How can this be normal? So then we have to refer back to how they define the stage 1 CKD, because if the cat also has a normal USG and normal sDNA, they will be in the stage 1 or not normal, healthy, non-renal cat. Same thing applied to sDMA. Some of them has sDMA above 18, but as long as they have a normal USG, they are not necessarily classified as stage 2 CKD. So at inclusion, among those 201 cats, those cats who had sDMA above 14, they do have them recheck in about 2 months. And those 21 cats who had a higher sDMA, 18 of them, the sDMA improved, and 16 of those cats had a normal sDMA at 2 months. At 6 months, 2 of those 3 cats who did not have a normal sDMA ended up had a normal sDNA. So what that means is sDMA did fluctuate, initially was higher, but later on that become normalized. Same thing applied to USG. 31 of those 201 cats had low USG, but after 1 to 6 months, 20 of those 31 cats, their USG normalized. So overall, there are 13 cats. They are classified as IRIS 1 stage 1 CKD cat. 10 of them had a USG with a persistent less than 1035. 2 of them had sDMA above 14, and only 1 of them has both in combination, but the creatinine is less than 1.6. Both means the USG is low, sDNA is high, but the creatinine is low. So the result, what I see over 2 years, what I found was in cats with CKD, there are like, for those cats end up develop CKD stage 2 or higher, definitely the cat with proteinuria, they are more likely, 21.6% of them develop CKD stage 2 or higher, but only 10% of those cats without borderline proteinuria develop CKD stage 2 or above. However, the differences did not really reach the statistical significance. For the cat who developed renal proteinuria, how they defined that was the UPCs persistently above 0.4. So what they found was, not surprisingly, 7.8% of those borderline proteinuria cat developed persistent proteinuria, but only 0.7 of the cats with a UPC less than 0.2 end up with a UPC persistently higher 0.4. Lastly, the death. Cat with borderline proteinuria more likely to die over 2 years compared to cat without borderline proteinuria. If we look at the data in a different way, they want to know like how likely those animals end up having the diseases. So the incident rates, what that means is for the 100, like how many cats out of 100 healthy cats will end up having a disease. So in the top part of this graph, there are 7 out of 100 healthy cats age over 7-year-old follow up for 1 year will develop CKD stage 2 or higher in this cohort group of cat. And the likelihood, the incident rate is higher in cats if they have borderline proteinuria, as well as creatinine over above 1.6, BUN above 37, and lastly, if they are already in stage 1 CKD. So 33, basically 1/3 of those cat with average stage 1 CKD will progress to CKD stage 2 within a year in this group of cat. Same thing applied to the renal disease. Renal disease, the definition in this study is either it is a stage 2 CKD or persistent proteinuria. So in this group of cat, 9 out of 100 healthy cats will develop renal disease for 1 year, within that 1 year. But it's more likely for them to have a renal disease if they already have borderline proteinuria and or creatinine over 1.6 and or they are already in average stage 1 CKD. So overall, the risk factor for those cat to develop CKD stage 2 over 2 years will be if they're already in stage 1, and if the creatinine is above 1.6, BUN is above 37, and age at inclusion. Basically, the hazard of ratio is 1.4, meaning every year per year of age, the hazard of developing CKD increases by 40%. Risk factor for renal disease development is similar to the CKD stage 2. Also, average stage 1 CKD, creatinine above 1.6, UPC between 0.2 to 0.4, and age at inclusion. One interesting finding of this paper is when they evaluate and follow up on those cats, in those cats ending up develop CKD stage 2 and higher, there are actually 2/3 of those cats, they have creatinine elevation above cutoff value 6 months before SDMA. Only 11% of those cats had a SDMA elevation before creatinine, which is markedly different from what I understand and what I've been kind of telling students and the clients. So that's one part of the very interesting finding in this paper. They also look at if they use a different reference interval, because the same group of this veterinary scientists, they did another study. They tried to look at the creatinine, age-appropriate creatinine reference interval. They used the creatinine 1.89 as a cutoff for this age group of cat, like above 7-year-old cat. So if they use a little bit higher creatinine cutoff value, there are 39% of the cat had a creatinine elevation above cutoff value before sDNA. And only 30.4% of those cat had a sDNA elevation before the creatinine. So the discussion part, they talk about the development of the CKD stage 2 and above, those cat, the borderline proteinuria cat, they are more likely to develop stage 2 CKD than cat without borderline proteinuria, but the result did not really reach the statistical significance. The reason why it did not reach statistical significance, they feel it's because we still don't know whether this low level of proteinuria is the cause, it causes a progressive renal disease, or it's just a marker of decreased tubular function. So it's like the proteinuria is the reason or the result that we do not know. Also, the neoplasia and other diseases can also cause proteinuria. And since there are a group of cats over 7 years old, they may already have some other diseases that maybe is not showing within these 2 years of time, but we just don't know for sure. They also discussed this lower percentage of cat develop CKD that had sDNA elevation before creatinine elevation, because in this study, there are only 11% of the cat had sDNA higher before the creatinine. Compared to some previous study, is 81% of cat developed CKD elevation before the creatinine elevation. So why they think there's a major difference between this study and previous study, because the CKD definition in the previous study was quite different. And also they use a different cutoff value for creatinine and sDNA. However, even when they use the age-specific reference interval, there's still a lot of cat has creatinine elevation before sDNA. So at the end, this paper does have some limitation because they diagnose iris stage 1 CKD based on USG and sDNA without other criteria such as like kidney renal images or renal biopsy, even though I couldn't imagine why would you want to do a renal biopsy in a client-owned, otherwise healthy cat. FGF23 was not measured, so we couldn't really know if there's any early mineral bone disorder in those cats. And some cats develop some comorbidities that could complicate the diagnosis of CKD and affecting the UPC. Lastly, those are group of client-owned cats in Belgium. So it could be there's some breed differences, diet differences, or they are more indoor or more outdoors when they neuter the cat that we just don't know. Among those 201 cats, there are actually 29 British short and long hair. So I don't really see those kind of cat frequently in the United States, but apparently they are more popular in Europe. My take-home point from this paper will be borderline proteinuria in healthy, mature senior cat is a significant predictor of future renal disease and death. So what I learned from this paper is I probably will monitor them more closely. I probably will monitor them not every year, maybe more close to like every 6 months or so, but just my own opinion. Then also the other take-home point, it will be, should we include UPC as a part of senior screening panel? Because some of them may have borderline proteinuria, but then what if we didn't catch that and we just don't know they have a borderline proteinuria? Lastly, this is still a question without an answer. Possibly early intervention in cat with borderline proteinuria, even in absence of azotemia, that we just don't know. We need more data for that. So that's the end of my presentation. if you have any questions or comments, please do share. Dr. Chu.
Yeah, I thought you did a great job summarizing that paper with particularly all the difficult definitions of what the various categories were going to be. You mentioned that Zoetis, I think, has a point of care albuminuria measurement. Can you tell me a little bit more about that?
Yes, it's like I need to find if I can. I went to their website, they have this, they just tell you the numbers, like a range. Say like, oh, it is between 0.2 to 0.5, but they wouldn't give you a actual number.
So
But
this is albuminuria, and
yeah,
it's a thing, it's a point of care test in the practice, the local practice, right?
yes, I
I
have
know
seen.
Antec will give you an albuminuria number. I
Mhm.
called IDEX, and they didn't think it was necessary ever to measure urinary albumin, which I thought was astounding. Um,
Well, I think in human medicine, they do feel it's a better test.
yeah, and the original test that they did at the Royal Veterinary College, they said they were kind of equal way back when, but we didn't have the reagents and the techniques of doing albuminuria back then when that original decision was made. So
Mhm.
I don't know. I like both of them at the same time. I like to have a UPC and an albumin because you want to know how much is albuminuria and you want to know how much is tubular proteinuria. I guess you could do an SDS page if you wanted to do that, but I'd like
Yeah,
to have something that is done on a routine basis where you'd get both of them. You'd know how much is tubular proteinuria. I mean, if you have a zero point 0.3 UPC, how much of that is albumin? If you have proximal tubular disease, you can get some albuminuria because the albumin processing capturing units there may not be functioning. So there could be albuminuria, or there could be tubular proteinuria, or there could be both.
yeah. It is called, from Zoetis, it's called VET-SCAN. And it say it can give you a result for urine protein creatinine ratio and microalbumin.
Oh, really? Okay.
Yeah.
Well, that's interesting.
I have seen the result from some referring vet's record, but they really just give you a range of number. They wouldn't
Mhm.
tell you exactly what it is.
Yeah, Zoetis makes a urinary dipstick that also has microalbuminuria on it and creatinine in it. It has never been fully validated, but they do sell those dipsticks that give you MA and urinary creatinine in bins, like a certain range, and then you can calculate out an approximate
So it's
microalbuminuria.
like UACR. You can
Yeah,
calculate.
but it wouldn't be the same as doing a benchtop analysis because bins overlap from lower, medium, and higher levels.
Interesting. I need to look into if I can find more information about that. But yeah, so that scan will only tell you if it's less than 2.5 mg per deciliter or above. So they will only give you, say it's a high or low. They wouldn't tell you more than that for
Well, no,
microalbumin.
so technically, I mean, you were probably weren't around when the Heska test was around. It was a point of care dipstick thing that you put the urine in, and it told you how much the microalbuminuria might be there.
Yeah. I think Haska is being bought by
Yeah,
Intech, and
it
then
was. Yeah,
when I
that's
went to Intech website, I couldn't find much information about that Haska test.
well, technically, no dog or cat normal that is 100% perfectly normal should have more than a milligram per deciliter, but their tests only went down to 2.5 milligrams. So if it's below 2.5, that was thought to be good enough.
Okay.
So if it's less than that, that's fine. What is the other bin that it gives you? If it's less than,
Just above or less, 2.5.
oh, that
That's it.
doesn't help you that much. I mean, at least if it's negative, if it's that would be okay, but you'd like to have another bin that it's marginally elevated or more markedly elevated.
Yeah, that's all they give you.
Yeah. I believe one of your colleagues is Dr. Herr is looking at urinary albumin creatinine concentrations with some chemistry company from Korea that is really looking at this in some detail right now at North Carolina.
That's great. That's cool. I don't even know if I want to do a UACR in animals. I Do you know where we can send it, or is there any place that can be sent to? Or you can do your own urinary creatinine and do your own calculation.
That's what, I think that's what you might have to do.
Oh,
I mean,
okay.
that's the interesting concept is, you know, that there never should be more than 1 milligram per deciliter of albumin in the urine anyway. So the question is, do you need to index it to the urinary creatinine? Some people do and some people do not.
Well, we definitely need more studies for that.
And you're the people to do it. So
No,
I'm looking forward to seeing some of those results. I think you did a great job summarizing the paper.
thank you so much. Appreciate it. Any other questions or comments? Okay. All righty, thank you.
Thank you so much.
Thank you so much.
Have a great day, everybody.
Bye.